name's Dr. Phil Brooks. I'm one of the senior registrars in the emergency department at Royal Perth Hospital, and I'm currently seconded to the Department of Anaesthetics. And this is a 5-Minute Friday on the airway. So I thought I'd focus really on the basics of the airway, because I think that those are the most important things, the most important skills to get right. And it's basic airway management that will get you out of a tricky spot in the field. It's basic airway management that will do the best for your patient. And we would certainly say that good quality basic airway management, including good bag valve mask ventilation and good oxygenation, is certainly preferred to multiple failed attempts at trying to secure an endotracheal tube. So with that in mind, talking about the basics, the first thing we'll talk about is bag valve mask ventilation. So there's very few airways that can't be satisfactorily managed with good quality bag valve mask ventilation and the use of an oropharyngeal or a Guedel airway. There's a few tricks when we talk about inserting a Guedel airway, which I'm sure that some of you are familiar with. And the first thing is, of course, to make sure that you select a Guedel airway that's an appropriate size for the patient. So these are hard plastic devices, and they should be sized from the two hard parts on the patient's face. One hard part being the incisor teeth, and the other hard part being the angle of the jaw. And that's where you want to make your size measurement to make sure you're using the airway that's the right size for your patient. When you insert it, initially 180 degrees to the orientation where it's finally going to sit, one of the most important things to do is to make sure that it's sitting in the right place. And to help the airway sit in the right place so it does the right job, which is to lift the tongue off the posterior pharyngeal wall and improve the flow through the airway, is to actually give the patient a little jaw thrust. And what that will do is it will just help the airway to sit nicely with the flange either on the patient's lips or sometimes even on the patient's teeth, and make sure that it's sat in the right position for optimum airway management. When it comes to use of the bag valve mask, there's also a few tips and tricks that I can share with you. The first one is to make sure that you're using a mask that's the right size for the patient's face. And secondly, you need to make sure that rather than pushing the mask down hard onto the patient's face, the best thing to do is to try and lift the patient's mandible up into the mask. And you'll find by doing that, you get a much better seal, and it's much easier to deliver bag valve mask ventilation. Also, it's really important that you look at the patient's chest when you're bag valve mask ventilating. You won't get any feedback from the bag or the mask or the patient's face as to whether or not the ventilations that you've given have been effective. So therefore, it's really important to look at the patient's chest and see the rise and fall of the patient's chest to make sure that you're actually delivering oxygen-enriched gas into the patient. It's also perfectly reasonable to use a combination of a Guedel airway and a nasopharyngeal airway as well. In fact, you can use 2 nasopharyngeal airways and 1 Guedel airway to make sure that you've got optimum positioning for airway management with bag valve mask ventilation. So talking about positioning, I think another really important thing with the airway is that you have to have your patient in the right position. So I'm currently working in anaesthetics, and we routinely have at least 1 pillow, if not 2 pillows, underneath the patient's head. And yet in the pre-hospital arena and sometimes in the emergency department, those pillows are often removed or they're simply not there. And unless you've got the patient in the right position, you're going to find airway management, be that basic airway management or more advanced airway management like intubation, really difficult. So the idea is to get the patient in a position such that their tragus, which is this little part of the ear here, is directly in line with the patient's sternum. So that often requires the use of a couple of pillows or rolled up towels, either behind the patient's shoulders or directly under the patient's head, to get that optimum airway position. And that's the best position for laryngoscopy, and it's the best position for airway management. So if you're on someone's living room floor trying to manage their airway and their head's completely flat on the floor, you might find that your airway management and your airway view when it comes to laryngoscopy is improved if you actually put a pillow or something else underneath their head to try and get that ear or tragus to sternal notch positioning. The other thing we talk about is ramping. And by ramping, I don't mean being stuck on the ramp with grandma waiting to offload her into assessment. I mean ramping as in positioning of the patient's airway for maximum success at laryngoscopy and intubation. And this is particularly important for obese patients, where if they're lying completely flat, the airway is very difficult to manage. And so we use a ramping pillow, which is basically a wedge-shaped cushion that goes under the patient to lift their head up so that ear falls in line with the sternal notch. And that's a much preferred position for airway management. And in fact, it's very difficult to manage somebody's airway when they're not in that position. So unless you put the effort in to get them in that position, often you can shoot yourself in the foot by not getting things properly set up. If you are going to have a go at more advanced airway techniques, such as intubation, it's really important that if you have a look with the laryngoscope the first time and you don't see anything, that when you look the second time, you have to make sure that you change something. And in between times, go back to what you know last worked. So if you were able to satisfactorily bag valve mask with a Guedel airway in situ, and the patient had good chest rise and fall, and you were oxygenating the patient well, that's great. If you look with the laryngoscope and you see nothing, just come out and go back to that because you know that that worked. When you go back and have a look a second time, you need to change something. Something has to be different. Otherwise, the view that you're going to get is going to be exactly the same. It might be a change of position. It might be a change of laryngoscope. It might be using an adjunct such as a bougie or a stylet, or even a change of provider, but something has to change in between attempts. Otherwise, when you look for the second time, you're still going to find an empty fridge. And the final thing I wanted to talk about was the cervical spine. So when traditional teaching about airway, we always talk about airway and cervical spine going hand in hand, especially in our trauma patients. And what I'd like to emphasize really is that the airway is the thing that has to take priority in that situation. So I certainly advocate C-spine safe maneuvers, but there's no point in having somebody with a beautifully intact C-spine if in essence they've died of suffocation because their airway has become obstructed. So your first priority is always going to be the airway. And there are no reported case reports in the literature of anybody having a cervical spine injury made worse by careful and appropriate manipulation of the airway to ensure that the airway is secured or protected. And a recent case of a very obese lady who lost her airway whilst lying prone after a fall with probable cervical spine injury, she was managed entirely appropriately and was moved in a way so that her airway was patent. And obviously we do that with as little trauma or additive trauma to the C-spine as possible. But remember, the airway always takes priority. So I think those are my key tips for airway management. Keep it simple. Remember that there are very few airways that you can't satisfactorily manage with a bag valve mask and a good fitting Guedel. If you can't intubate, it's not the end of the world. Laryngeal masks and other supraglottic devices are certainly there to get you out of trouble. Intubation isn't the be all and end all. What's most important is good quality bag valve mask ventilation and good oxygen delivery. And that's what's going to prevent horrible outcomes like hypoxic brain injury in your patients. And remember, if you are going to intubate and you have a look and you don't see anything, make sure that you change something before you have a look again. So we'll wrap it up. That was your 5 Minute Friday on the airway. Thank you.